So welcome to our drop-in session. This is the first time I've done this. I may have lost some sleep over it. So thanks for being our first pilot group. The request for this talk came through from some teams that had encountered managing preterm birth and recognizing that there was some unique preparatory and equipment needs that they hadn't necessarily thought of or planned for. And so we got asked to put this presentation together. So that was the impetus. And I called it, but we don't do that here, because so much of the time, especially with perinatal care, it's all well and good. And many of our administrators can think, well, we don't offer that service. So we're not going to staff for it. And we're not going to, we're not designated to offer that service. And nevertheless, as we know, babies choose to be born many times in circumstances that we might not have asked. It's good preparation for parenting when we have to realize we're not in control over and over and over again. So despite not planning to offer preterm birth, sometimes we are in the situation of needing to manage it. So we want to be sure that we've had the chance to think and plan and get ready so that it's not so scary and that we can offer the best care. I want to take a moment to acknowledge that I'm calling in from the traditional territory of the Comox, Puntlich, and Ayixen First People, who have been having babies, who grow up and have babies for many thousands of years in this community. And I'm extremely grateful to be talking to you from here. If anybody else would like to tell us where they're calling in from today and acknowledge those territories, I'd welcome it.
Yeah, I'll chip in. I currently live on unceded coastal Salish territory, and I have the privilege and honor of working on and working with Heiltsuk First Nation.
Thanks, Adam.
I'm from the Rural Coordination Center of BC. We coordinate the sort of provider-facing pathways for real-time virtual support. And I am coming to you from the unceded traditional territories of the Kwantlen, Semiahmoo, and Katzie people in Surrey, BC.
Thanks, Rebecca. And we'll just acknowledge that, of course, we're representing people through our real-time virtual support from traditional territories across our province, and gratitude to the communities that are helping us continuously strive to improve our care and eliminate anti-Indigenous racism within our healthcare systems. I have no disclosures. I'm not paid by anybody, although I am paid by real-time virtual support to do this presentation, but I don't have any relationships with pharmaceutical industries. Alicia, if you're welcome to chime in if you have anything to disclose, otherwise I'm going to assume you also have.
No, I do not have anything to disclose other than I'm paid by RTVS as well, but I have no other connections. And my apologies, I am coming to you from Kelowna, BC, so I'm on the unceded territory of the Silk Nation, and I acknowledge that we live, play, and learn here together.
Thank you. So this is just the structure for the chat we've put together. I'm going to take the part one about preparation and hopefully maybe avoiding the situation where we are managing a preterm baby. How can we identify risks for preterm birth, identify preterm labor quickly, and facilitate optimal transfers and possibly best care, what interventions we might take where we are to improve outcomes. Then I'm going to hand it over to Alicia to talk about preparing for the arrival and management of preterm and late preterm infants, and then a little opportunity for discussion relative to your sites or where you work and how we can support you in these situations. So classic definition, preterm labor, the definition there is regular uterine contractions with progressive cervical dilation and or effacement, greater than 20 weeks, because before that we'd be talking more about a miscarriage, and before 37 weeks when we generally be considering that baby to be term. And preterm birth is when that baby's actually born. The the long-term adverse sequela, like the highest risk babies, we're generally thinking of as less than 34 weeks. But I don't know about those of you who have to call for specialist support, sometimes from women's or arranging transfer. You know, the difference in how I feel in the Comox Valley managing a 34-week baby is very different than how the perinatologists might feel in Vancouver when they're talking about a 34-week baby. How at risk those babies are can feel very different depending on the resources you have at hand. So preterm birth in Canada is, as of 2009, roughly 7.7%. And one of the most important factors here is the accuracy of pregnancy dating. And so I have a question for you to reflect on, which is, what is the best method for accurately dating a pregnancy? And Taylor or Adam, feel free to chime in if you have an opinion.
I've always assumed it's ultrasound, although I guess if there's only ever been one episode of sex, then you could run off that.
Yeah, IVF dates are probably the most accurate when you know that embryo was implanted. And yeah, some people really have a good memory for like what the day was that they believe had happened. But as I often chat with people about, you know, we don't know when sperm actually met egg, and we don't know how long it took that little embryo to actually implant. So the most accurate method is considered to be ultrasound, sometime between 7 and 14 weeks. And we've really seen that as we have instituted the expectation that women with access, patients with access, will have ultrasounds for dating, we see less, in fact, induction usually for post dates, but 7 days can make a world of difference. If we're looking at, is this a viable preterm birth? Is this a preterm baby? Is this an overdue baby? So remembering when we're starting the process of evaluating somebody who might be in labor and it might not be the time we were expecting, first how accurate those dates might be, because a lot of people who might live in quite remote or underserviced areas may not have had access to an ultrasound at all, or maybe not until much later when their dates might be a little less accurate. And I should say, I'm going to probably slip into using, pregnant woman or pregnant person interchangeably. And please know that my expectation is many people have different expressions of gender, and that all are welcome, but I might slip into maternity or pregnant woman for simplicity. So I have an opportunity to brainstorm just some of the risk factors for preterm labor and birth. Does anybody have any that they would think of off the top of their head?
Short cervix found at dating or anatomy scan.
Mm-hmm.
Previous preterm birth.
Excellent. Yeah.
Diabetes.
Mm-hmm.
IVF, assisted reproduction.
Mm-hmm. I'm going to pull up the list. So they're kind of divided into spontaneous and iatrogenic risk factors. So among the spontaneous ones, exactly like you said, previous assisted reproduction, any situation where there's bleeding, of course, fluid leaking that might represent pre-labor rupture membranes, the cervical factors and the uterine factors like large fibroids or bicornuate uterus, fetal conditions. The infection piece is interesting, and you might have come across that. Like, really, they're looking for sort of now suggesting that screening for bacterial vaginosis only if there's been a prior preterm birth, not screening universally and treating as an intervention to prevent preterm birth. Young age and older age, and then all those social determinants issues, substance use being a big factor there too. And then the iatrogenic, I need an extra click, whoops. There we go. Iatrogenic risk factors, like reasons that we might be looking to deliver somebody early, which is going to be less the situation that you're managing in Bella Bella, for example, but maybe is something that you're transferring somebody out from Salt Spring to another community earlier than expected for a potentially planned preterm delivery. So predicting preterm birth, wondering who is at risk. The question here is, if a pregnant woman arrives to, say, our nursing station in a remote community with moderate cramping every 10 minutes at 32 weeks pregnant, what tools might help you predict her risk for actually being in preterm labor?
So I very recently learned about fibronectin, but I've never used it or come across it, and I don't know where it's available.
Do you know if you have it in Bella Bella?
I don't know if we have it in Bella Bella.
Yeah.
I suspect we don't.
On Salt Spring, we don't, we do fetal fibronectin, but we don't have the capability of running it. It has to be sent to Victoria. So we'll do, I can never remember what it's called, like a pig fib, which we can do in our lab. And if it's positive, they send the fetal fibronectin to Victoria, which usually our patient beats them there. But if it's negative, then they don't send the fetal fibronectin.
Thanks for bringing that up. And I don't have the Actum Partis or PG, blah, 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 because it's not used in the other health authorities. So I didn't include it in the presentation, but it is one that might be of interest for places without the lab service, as you mentioned. So, of course, our clinical evaluation has a role to play in evaluating risk of preterm birth, but those two tools of fetal fibronectin and sometimes transvaginal ultrasound can be really useful. Obviously, though, really limited when we're in low resource settings. So our clinical cues that we might look for are, I always think, when in doubt, examine the patient and start with a history. What are those contractions like? Are they regular? How uncomfortable are they? Is there associated bleeding, fluid leaking? And what's going on with her cervix? With that caveat, my little clicks aren't working properly. So this is where I was going to mention, like, when we are living and working in places that aren't set up to deliver or before a certain gestation, counseling women on those early subtle signs is a really important thing that I'm sure we're all doing when we work regularly there. But if we're working intermittently, it's so opportune to have the conversations. It's not super specific, and at least 50% of people with regular mild contractions and maybe some softening of their cervix aren't going to deliver preterm, but that might be the window that we have for safe transfer when we're working in really low resource sites.
Sarah, I've just discovered we do have fetal fibronectin in Bella Bella, which is mildly exciting for me.
And do they, the next question would be, do they have 24-hour lab?
Yes, if I need it.
Good. Yeah.
It involves waking someone up, but I don't mind doing that.
I worried that this slide was going to be too granular, but actually this might be perfect information for you, learning that, like, the fetal fibronectin,
I call just-in-time learning.
Stats around it, yeah, are, it's a really good rule out test. So if it's negative, there's only a 1 to 5% chance that that person is going to deliver within 14 days. And that's huge for somebody who might not have to have a flight out of community and a disruptive stay and all that stress of transfer. It's not a great test if it's positive. Only 17 to 41% of those people will deliver within 14 days. But nevertheless, it can be the thing that can really help you argue for, yes, you need to send that plane, or, okay, no, we can calm ourselves that it's safe for this person to stay here for now. It's useful under 34 weeks, but we want to think about it right away when we're starting our evaluation for somebody, because we want to avoid doing any vaginal examination before. So we want to wait on doing a cervical check until we've collected our fetal fibronectin, because we risk a false positive, and asking that person, have they had intercourse or a vaginal exam in the preceding 24 hours? I mean, it might be that you choose to do it anyway, but that there's just that higher chance that a positive result is a false positive. But a negative fetal fibronectin is a wonderful tool. And then the transvaginal ultrasound is not going to be something most of us are able to call on, but with more and more point of care ultrasound, it might come into our skill sets. Basically, the cutoffs there being if a cervix is longer than 30 millimeters, at 24 weeks gestation, this might help reassure us about somebody who we think of as quite high risk for preterm birth. Maybe they've had on and off cramping and the occasional spotting, and they delivered preterm last time. So it might be something that can help us evaluate that person's risk. So yeah, they can help us more accurately diagnose or recognize preterm labor, and they can reduce unnecessary hospitalization, transfer, or intervention. But the downsides there, as we've already mentioned, are that we require trained staff, lab services, and ultrasound resources for the ultrasound component. So when it comes to managing preterm labor, again, I always go through my systematic patient assessment. We're going to take a history about their pregnancy, their past pregnancy histories, medical, surgical, social history, medications, and allergies. I think often when someone, walks in like that patient I might have mentioned, 32 weeks cramping to Bella emerge, we can immediately get so keyhole focused on, oh my goodness, we got to know if this woman's in labor, that we can skip over doing this systematic approach. And all of this information can become extremely relevant when we start to do our management. So it's really important. And I'll always just make my little template for evaluation of a patient to make sure I cover these things. The physical, making sure we've got blood pressure, heart rate, all the usual stuff. Fetal heart monitoring, if they're over 24 weeks, ideally, we have the chance to do continuous fetal monitoring, but if not, making a plan for how frequently we're going to check in with intermittent auscultation. And the tocodynamometer with manual confirmation can really help get a sense of, are these palpable contractions? How intense are they feeling manually? Position of the fetus obviously is really important for our preparation if you have bedside ultrasound capacity, or call in ultrasound to know if you can't tell if baby's head down or bum down. And then thinking about a pelvic exam, saline without lubricant if we have a fetal fibronectin, and doing that speculum exam first. Trying hard to remember to collect a group B strep culture if possible that might go with that patient or be processed. And visually assessing the cervix, looking for fluid, and then followed by a digital exam for effacement and dilation. So this is the mnemonic that I like to use when I am preparing to transfer a woman or patient in preterm labor at my site. STAT-M is a mnemonic for helping remind me what medications and interventions to consider. Does anybody know this and want to volunteer it, or can you make a guess at what those letters might stand for? This is one that I keep in my little cheat sheet notebook in my purse. So
I don't know.
Oh yeah, go ahead, Taylor. Sorry, I didn't give you enough time.
Oh no, that's okay. I was just gonna say I don't know it, but I was going to say steroids, toecolytics. I don't know the other letters, maybe fluids, to see if we can slow down contractions. Those are the only ones I've got.
Awesome. That's great. You're exactly right. So steroids, tocolysis, can we somehow slow or pause this contraction pattern? A is actually for antibiotics, and thinking about group B strep. It's funny how these little clicks work and then they don't work. There we go. A for antibiotics, T for transfer, and M is the one that was added more recently when magnesium sulfate became a thing, which I'll briefly cover. Good point, Taylor, about fluids. We'll often consider giving a bolus of fluids just to see if, is dehydration leading to some uterine irritability and contractions, and it's not really on the mnemonic, but a good one to think about. So the steroids, which most of us are familiar with, would reduce incidence of RDS, necrotizing enterocolitis, IVH, PPHN, which is persistent pulmonary hypertension of the newborn. IVH is interventricular hemorrhage. The maximum benefits after 48 hours. And we're trying to give it when we think delivery might happen within the next 7 days. So this is something that when you're transferring somebody, I often find I'm always checking with the receiving site that's going to take my patient about, do you want me to start this? Are we on the same page that this is a good idea right now? A couple of weeks ago, I sent someone out with a very short cervix and bulging membranes at 24 weeks. But she wasn't in labor. And so we were really on the fence and talking with our receiving site about, should we administer these steroids now, or should we wait? Because if she doesn't actually go into labor and she gets a cervical cerclage, then there are harms associated with unnecessary steroids. So anyway, somewhere between 24 and 34 plus 6 gestation, possibly 35 to 37 in consultation. And I put the doses there just for your interest of the 2 different preparations that we would use, and different hospitals might have access to different ones. The tocolytics that we're using, I think most of us are pretty comfortable with nifedipine in other contexts if we're family physicians working maybe in a combination of emerge and family practice, but it's the immediate release preparation, not extended release. And I won't belabor the regimen, but it's more sometimes nice to have that to refer to. If you have specific questions, let me know. The indomethacin is something that we really use just for transport, ideally, and we don't want to use it after 32 weeks. So this would be something that we might use for that person who's contracting 30 weeks, going to be flying from Bella Bella down to Vancouver, and we're just trying to make sure that we do everything we can to prevent her contractions picking up throughout that transfer. So those are rectal suppositories. Nitroglycerin you might see listed or hear someone ask about, but there's insufficient evidence to support its use. So that's something that we're not usually touching now. But the contraindications to tocolytics would be if delivery is happening, abnormal surveillance of the fetus, significant bleeding, or if we've had demise, like slow me down if you want me to in any part of this. The antibiotics is primarily for group B strep. You might hear, or you might talk about with some sites, antibiotics to promote latency. I think that's kind of heading out of favor. Basically, if someone has the regular painful contractions and group B strep is unknown and delivery seems to be anticipated or imminent, then it's great if you can start or give a first dose of penicillin G if they aren't anaphylactic or allergic, cefazolin if they're allergic but not anaphylactic to penicillin, or Clinda or Vanco if they have penicillin anaphylaxis. So getting those doses started while somebody's waiting for transfer can really make a big difference for that baby. And then the magnesium sulfate is probably not something that would be started in a remote site prior to transfer. I don't know, Taylor, if this would be something that you'd ever be looking at starting on Salt Spring while you're sending somebody to Victoria, which is a pretty short transfer if it all lines up. But just for your information, that this is something we're now thinking of for the very preterm babies as neuroprotection. And it's really ideally started within 4 hours from birth, and discontinued if delivery hasn't happened within 24 hours. Transport considerations.
Sorry, can I just ask a question?
Please.
If you don't mind, yeah, so it said it should be discontinued if starting Meg-Sulf, like tocolysis. So is the idea that Meg-Sulf, you're saying it's neuroprotective, so you're going to have to decide which one you're going to go for. So essentially you're kind of like, it's not going to slow anything down. It's just going to be more protective. So you're kind of going into a state of knowing that you're going to deliver this baby and just trying to do what's best for them in that moment.
Exactly. Yeah.
Okay.
So if you're going to magnesium sulfate, it's because we're expecting delivery is going to happen. And so we're not going to be still trying to slow that birth process down with tocolytics. Okay. And magnesium sulfate used to be thought to maybe be a tocolytic option, and it's not considered a tocolytic in and of itself anymore. So that there might be some confusion if you're talking about using it with people who are familiar with maybe having used it in the context of tocolytics previously.
Gotcha. Thanks.
Is that something that you've ever seen? Like, would you consider starting magnesium sulfate at 30 weeks if you're sending somebody? Is that something that's happened to you?
I've sent, like recently I sent a 34-weeker and I was told that I wasn't going to be able to send them and I was going to have to manage them for 12 hours. So that's just kind of interesting to me, thinking like in those moments we did get her off the island, but I would hope to never have to get into the state of like, okay, I'm going to switch over to Megsulf because this baby's coming out here. But of course it's a possibility. So that's good to know.
Well, and it is nice because many of us who would deliver babies at some point, or I mean, really maybe all of our sites should be prepared to manage preeclampsia. And
yeah, we do have it. Like we have a protocol for preeclampsia. So I know that, you know, my nurses are somewhat familiar, but yeah, it's not something we do often or hope to do.
Yeah, but you know, you're exactly right. Like if that baby is going to be born with you, whether you like it or not, then
Yeah.
having magnesium sulfate on board, if they're delivering at 32 weeks, could be of benefit.
Yeah, and I've never heard of this before just because it's not usually me doing those things. So now that I'm in a remote site, that's really helpful to know.
And something that your consultants, you know, be it myself as a MaBAL person on a call with you, or a Charlie doctor, or a neonatologist helping you remotely, might be saying, do you have this? Can you run it? And if your team has kind of thought about it and prepared for that, then that won't feel quite so scary.
Yeah, exactly. And having some knowledge behind why we're doing it and whatnot. That's great.
Oh, good. So yeah, transport considerations, these I'm sure you're very familiar with. Everybody always thinks, oh great, we'll just transfer them and poof, there they go, and all is well. But so many things can interfere with our ability to safely transport somebody. Contraindications to transport might be if mom is unstable, if the fetal surveillance is abnormal, although some strong considerations when you're in somewhere really remote about whether that's still reasonable to transfer, if delivery is happening, if you can't send anybody to attend with that person, or if whether too hazardous. And this is just that little reminder that the very worst place to have a baby is on a highway or on a ferry or on a plane. So even while we might feel like, oh my goodness, this is not the best place to have this baby, we should all feel good that we're better than many other places could be. And we do have so much to offer. And our TVS teams are here to support all of you if you're ever in this situation. And with that, I think I'm going to hand it over. And I'll save questions until the very end, just so we make sure that we don't take up too much of your time.
Great. Thank you, Sarah. I certainly learned a lot listening to that. Usually those are some of the questions I'm asking, what's going on, and yeah, it's all super important information. So my name's Alicia. I am a pediatrician and I work in Kelowna, BC, and I'm one of the doctors that works for the Charlie RTVS program. So just a little bit of background, in Kelowna here, we have a NICU that takes down to 30 weeks. So I'm lucky we're very resourced. And I have some background of working at higher level nurseries in Vancouver prior to moving here. And I've been happy to just support some neonatal resuscitations through Charlie. And we're always happy to do that. So moving forward, I just wanted, I thought, I guess I can, I'm not sharing these slides. Sarah, maybe. Oh, do you want me to just share them, Sarah, so I can move? Oh, you're just muted still.
Blah, blah, blah. Yes, I can either click it along for you, or if you want to just.
It's okay. I'll just try to share my own screen, although there it is. I was
beautiful
having
picture.
Oh, thank you. I was having some trouble with, how do I put it into presenter mode? Where is that?
It was just in it when I think you've got it on preview right now. So if you fully open the document, like just double click it and then click present on the top right when it loads.
Okay, sorry, I'm not the most savvy person.
There you go.
Yeah, there we go. Okay,
and it'll just come up on the top right in a second. There you go.
It's still, there we go. Okay, so I'm just gonna click through all these wonderful slides to mine. So I thought I would talk mostly about preparing for the birth of a preterm baby, a little bit about some physiology, just for helping understanding things. And then just some really quick things about NRP, which is really how we resuscitate all babies. And so really interesting, I mean, obviously, Adam, you've been working up in Bella Bella, Taylor, you're in Salt Springs. So I would love to hear what kind of equipment you guys have available to you as well, because a lot of what I talked about, I realized that there's going to be a range of what's available from a resource perspective. So I'd be really curious to hear. So just to begin here then, I'm just going to move this because I can't see my slides. Yeah, so preparing for preterm birth, so some considerations about why preterm babies behave like they do. So just some physiology to keep in mind. Anticipated issues for prematurity would be respiratory distress, secondary to premature lungs and or surfactant deficiency. They have trouble with thermoregulation, hypoglycemia. Often there is a risk of sepsis because sepsis or infection is one of the reasons for preterm birth, or we don't know GBS status. And then depending on how quick you can get this baby out, you may need to try to have some sort of intravenous or umbilical access. So these are the general considerations. So quickly, just so we can have a little review. So lung development in general is quite a complex process. It actually continues to occur up to 2 years of age post-term birth. And for effective gas exchange to happen, we need both fully formed alveoli and surfactant. So from an alveolar perspective, the very primitive forms of the alveoli start to exist around 24 weeks, but the fully formed, like fully functional alveoli don't really start to appear until about 32 weeks. The other important thing is the surfactant. Its production begins quite early, around 20 weeks, but the production of the complete surfactant molecule doesn't really happen until around 34 weeks. So whatever surfactant is available prior to 34 weeks may not be fully functional, hence the higher risk of respiratory distress syndrome or surfactant deficiency in the preterm baby. So I didn't dive a lot into like fetal transition or circulation or all those things, because I think I wanted to focus most on what we need to support those considerations that we talked about. Excuse me. So preparing for birth. These are some of the things that we ideally want to have available to us when we have the imminent delivery of a preterm baby. So probably I would argue the most important thing that we have is some way to provide positive pressure ventilation with oxygen delivery. And I realize that this may vary from site, and there's various ways to do this. And I'll talk a little bit about kind of the equipment that we use later, but there's various ways. So we have something called a T-piece, which is probably the most common thing that you'll see these days. You can use a flow inflating bag, you can use an ambu bag. So whatever you have to be able to support an airway or give a baby breaths, with the ability to connect it to an oxygen delivery device. Section with a catheter, something for thermoregulation. So there are various ways to provide thermoregulation. There are heating pads that can be purchased that you kind of like crack and then place underneath blankets so that the baby is lying on a heating pad. The neonatal nest is one of these. In the absence of that, as many warm blankets as you could get to make the environment warm. If you happen to have the availability of an overhead warmer, or if you're looking at a more preterm baby, typically under 32 weeks, we actually suggest placing them into a polyurethane bag, which in itself has its own cumbersome issues, but is very good for thermoregulation. Another consideration is to turn the heat up in the room that the delivery is happening in. So especially in the OR, ORs are very cold. So if there is an OR happening, I realize probably not in Bella Bella or Salt Spring, but turning up that temperature is important. Ideally, there's some sort of ability to put in an emergency umbilical vein catheter and some availability of resuscitative medications such as epinephrine. More specific equipment when we're talking about the airway, I'm a really big proponent of laryngeal mask airways, so LMAs. These are much easier to use than ET tubes and can be super handy in a pinch and can actually make a huge difference to establishing ventilation. And they're becoming more of a cornerstone in NRP. So the LMAs that we use in babies are size 1. Unfortunately, they don't come in a smaller size than that. So they're a bit limited in smaller preterm babies. So kind of less than 34 weeks, you probably wouldn't be able to use them. But preterm and term babies, sticking an LMA in is a super awesome thing to do. ET tubes with a laryngoscope, ideally you have access to size 0 and 1 blades, O2 sat probes and ECG leads, and then a neonatal resuscitation record, of which there's a provincial one, which I imagine everyone would have access to, because recording is important. So this is a picture of a panda or a giraffe warmer. This is kind of like an all-in-one unit that we use here, and most sites that deliver babies have them. They are kind of like an all-in-one. So they have an overhead warmer, they have a T-piece, which has the ability to provide positive pressure ventilation. They have a suction catheter. Then this is the area that you use for the baby stabilization and resuscitation. So obviously these things are ideal. They're a great kind of one-stop shop for most of your needs. I'm super curious, in Bella Bella and Salt Spring, what kind of equipment do you have to receive a baby like that?
We have a Panda in Salt Spring.
Wonderful.
We have a thing that I haven't actually looked at, but looks identical to what I was using in the 1990s, and it was called a Resuscitative then. So I haven't poked around at it, and I'm not entirely certain what it is. I just noticed it was there in case I ever needed it.
Well, Adam, I encourage you to poke around, because then, you know, if you have to use it, you'll actually know. And I'm sorry, I don't know what it is. Otherwise, I would help you talk you through it, but I don't actually know. And similarly for you, Taylor, are you familiar with how to use your Panda?
Yeah, definitely.
Yeah, good. Like how to set it up and turn it on. And I didn't go specifically into that because I didn't know what everyone had, but I just always encourage people to become familiar with the equipment that you have, and even practicing setting up for this scenario when it isn't actually happening, I think is a very valuable thing to do, so that in the time when you're stressed, you actually have a bit of muscle memory on how to actually do it. So preparing, so the setup, so you have all the equipment, hopefully, that we've listed, and you're able to have at least some parts of it. When we're setting up our warmer or our resuscitation space, whatever that may look like, some of the considerations we always talk to you, maybe increase the temperature in the room, get your warm blankets. What we want to sort of start with on our Panda warmer or on our resuscitative equipment, we want to set our T-piece or our positive pressure ventilation settings to a PIP, a top pressure of 20 and a bottom pressure of 5. That's what we're going to start with if we're giving baby breaths. We want our suction catheter to be somewhere between like 80 and 100 to be able to suction appropriately. When it comes to where we're starting for FiO2, if you have a baby that's going to be born at less than 30 to 32 weeks, there's some evidence to suggest we start them in a little bit of oxygen to begin with. So NRP doesn't mandate, but suggests that you could start in an FiO2 of 30%. Otherwise, we always keep our FiO2 at 21%, and we will increase that if we need to. We want our warmer to our maximum heat, and we want warmed blankets. We want the availability of our monitors. So our SAT probe and ideally our ECG leads ready to go so that you're not fumbling. Usually what I do is I take the SAT probe and I put it on the right side so that it's just ready to be placed on the right side, on the right wrist, which is where we should be measuring our saturations from. So that is actually just the setup we want for any delivery where you're anticipating any resuscitation. So in a preterm delivery, that is a risk factor for resuscitation. So this is what we're looking at. It's important to have available airway and resuscitative equipment should you need it. So if you have that LMA and it's the right sized baby, fantastic. ET tubes and blades. I didn't want to get too prescriptive here, but I just put down some of the size considerations. I try to keep it as simple as possible, especially when it comes to what size ET tube should I be reaching for. The smallest ET tube that you would probably see is a 2.5. In high-level NICUs, we sometimes carry a 2. Basically, any baby less than 30 weeks, you're going to be reaching for a 2.5. Between 30 weeks and term, it's usually a 3, and then a term baby, it's a 3.5. So I try to just keep that in my mind, like less than 30, 2.5, and then 30 to 37, it's usually a 3. And it's probably easier to try to get a smaller ET tube in rather than shove a bigger one in there. You might have a leak, but it's probably going to be more successful. In terms of a blade that you might use for an airway, in babies, we really often use the straight blades, which are the Miller blades, because they have really big floppy epiglottis. So we use that blade to push the epiglottis out of the way rather than using the curved blade, which typically picks up the epiglottis. There's a really big size discrepancy between a 0 and a 1 blade. If you ever get to look at them, it's like, I don't really understand why there's such a big size discrepancy. So sometimes for even like a late preterm baby or even in a rare IUGR baby, I'll reach for the 0. UVC kits, most sites, at least that I've seen, have like a kit where it's like, you know, everything you need to put in a UV should you need it is in that kit. So the line, the tie, thing to clean, the flush. So I would check with your sites if you have something like that. And the line usually comes in 2 sizes, so a 3.5 or a 5. Again, the 3.5 is going to be easier to get in. I would just say for a preterm birth, just reach for the 3.5 if that's what you're going to need.
Alicia, can I ask a question?
Yeah.
So someone asked me recently, what about IO? And what I realized was so much emerge training is moving toward IO for quick access. Of course, in the newborn, we've got this golden vessel, but actually the process of putting in a UV is fairly, like, yes, it's easy to access compared to putting in an IV, but the technical process is still quite slow. And I did one recently with a pediatrician here, and it really took both our hands to get it all set up properly.
Yeah, that's a really good question. IO? Yeah, IOs are certainly totally reasonable in term babies. I've never seen it done in a preterm baby. I think it would be reasonable in a late preterm baby. I don't see why not. I just don't know, like the smallest needle sizes I've seen for IOs. I think it would just go right through a small preterm baby. So in a term baby, say like a post-dates baby who's flat from MEC or something and you're struggling, yeah, I think you could do that. But I think in the preterms, we still need to go with the UVs. Good, like super good thought though. Yes, I'm a huge proponent of IOs in the pediatric world. So what about team members? And I realize in resource limited settings, this is yeah. So ideally, when I go to a preterm birth here, I have myself, I have an RN, maybe even 2, and an RT. Typically what we ideally want is someone who's the resuscitation leader, who's at the head of the bed, who's going to be guiding the resuscitation process, someone who's going to be able to listen to the heart rate and the air entry, which are the cornerstones of NRP in terms of deciding whether we're effectively ventilating this baby, and someone to record. So is that a possible thing where you guys are, do you think, to have that many people? Yeah, okay, that's great. Yeah, nice additions would be RT there, if you ever have, or a 4th RN to help with meds and equipment, because sometimes very quickly you realize that you need more hands. But at baseline, it's great if we can have 3 people. So that's kind of the equipment stuff. Did you guys have any questions about setting this, the resuscitation space up, or any of the equipment that I talked about having available? Like I said, I think it's good to, like, if you have time, wander over to your resuscitation unit, take a look at it, see what's available where, so that you know where to reach for things when you need them, so that it's not as stressful. So, okay, so we've got ourselves set up and then this baby is born. So this is probably the most stressful part. So resuscitation of a preterm baby is the same principles as resuscitation of any baby, which is the neonatal resuscitation program. I put NPR there. You can see I was tired when I was putting this together. It's NRP. Yes. Okay, so it's not different. It's NRP the whole way through. You're just dealing with potentially a smaller baby with a smaller airway who's at a higher risk of requiring some resuscitation. I'm going to briefly go through NRP in a couple of slides, just as a nice reminder to everyone, but here are some considerations when it's a preterm birth. So we talked about potentially starting with a little bit of a higher FiO2 if the baby's less than 30 weeks, especially. less than 32 weeks, placing in that polyurethane bag. So the bags, like I learned this semi-recently, it can be kind of any clear plastic bag. It's not like a special bag. It's just like put the baby in a bag, like a grocery bag, because it holds in heat. The thing about the bag, two things. It's hard to get the baby in the bag. They're sticky, they have vernix, they have fluid on them. It's like a little bit tricky. And then people get flustered about, well, there's a bag up to here, so what about putting the monitors and stuff? So it's a bit tricky. So some people suggest, keeping the bag on and then cutting a hole to put your ECG leads on. Usually we keep the right arm out so that we can put the SAT probe on. Honestly, what typically happens is that the lower half of the baby is in the bag and then it's kind of up here and there's ECG. It's a bit of a mess, but I would suggest trying it because it does help with thermoregulation. Those warming pads are actually really great. So if your sites have those are great. This is a pearl mostly about the babies that are like a little bit later, like later preterms. So your 34 to 35 weekers, they very often come out screaming unless there's been, problems with the fetal heart rate or something like that. The trick is they'll come out screaming and you're like, this is awesome, this is so good. You put them on mom's chest, yada, yada. Just be aware that they will run out of reserve often quite quickly. And so, they can develop respiratory distress. And so I do, even if they look great, I typically bring them over to the warmer by 5 minutes at the most and take a look at them, measure their sats, see what their work of breathing is doing and seeing how they're doing. The other thing they can do is they scream and then they have stiff lungs because they don't have surfactant and then they pop a pneumo. So just things to consider. I would suggest always evaluating them even if they look great. Okay, so NRP, are you, Adam and Taylor, have you guys taken NRP?
Yeah, I have to do it every year.
Perfect.
I did many years ago when it was called something different, but I have not done it in many years.
Yeah, it would be a great course, and you know what? We're actually trialing doing virtual courses through our TBS. But if you ever get the chance to do like a hands-on, it's a one-day thing. It's a great one to go through. So the entire goal of NRP, which is really interesting compared to any other population that we resuscitate, children, adults, which focuses on cardiac. The entire goal is ventilation to support normal fetal transition. Because for babies to transition normally, they have to take that first appropriate breath, expand their lungs, decrease their pulmonary pressures, and their whole circulation needs to switch to like a left-sided perfusion. So that's the whole goal of NRP. And I'm not going to go through it step by step, but basically, it's basically outlined as such. So when a baby is born, you take a look at them. What are they doing? Are they breathing? Do they have any tone? If they're breathing, do they appear in any distress? What does their color look like? We always, warm them, dry them, stimulate them to try to get them going. And then we reassess those questions again. Is the baby breathing? What is their tone? Do they appear to be in any distress? The core principles, if you're having to resuscitate a child, a baby, they're not breathing on their own, they're not effectively breathing on their own, is providing that positive pressure ventilation. And the acronym Mr. SOPA is what we use to move through the steps to provide effective ventilation. So we start by placing the mask and we start by giving the baby breaths. We evaluate, what's the heart rate doing? What's the ventilation looking like? So is there air entry now? Is the chest moving? Has the heart rate improved? No, okay. Let's reposition our mask. Let's get a better seal, consider a shoulder roll. Is the mask the right size for this child? Do a few more breaths. What's our heart rate doing? What's our air entry doing? Is the chest moving? Have things improved? No. Okay, let's move on to maybe sectioning out the oropharynx and trying to open the mouth a little more. Sometimes I find I actually have to pinch the mouth open. If you go through those steps and you're still not getting much response, then it starts to try to increase our airway pressures, particularly our PIPs. So we're going to start going up, giving the baby more pressure in those breaths, especially in preterm babies. This is often needed to expand those lungs. So this is why it's good to be familiar with whatever device you're using so that you know how to increase and decrease those pressures. So you want to go up to 25, reassess, and then to 30, and then you're going to start considering your alternative airways, i.e. your LMA, or whether you need to be intubating. I didn't put this on here, but there used to be a recommendation that all babies born with meconium, we would like take a quick look and suction out the meconium from their cords. That is no longer a thing. We go straight to resuscitating them with positive pressure ventilation. If it's like a super thick mech and you like look and you can see that there's an obstruction there, you can do that. But otherwise we proceed as normal. And the best indication of effective ventilation is improved air entry and heart rate. So that's why you need that one person. I literally get them to listen just almost the entire time. And I think I put that here with some of my pearls. So as you go through your steps of Mr. SOPA, you're going to be nervous. It's going to be scary. You're ventilating a baby who's not breathing. It helps if you count the breaths in between your steps out loud. So do 5 breaths. Have your dyad partner listening to the heart rate and the air entry as you're doing your breaths and giving you consistent feedback. Get your ECG leads and your SAT probe on while that's happening. People have this reflex of wanting to always turn up the oxygen. As soon as you see that maybe you get a pickup and your O2 is below what is the suggested target, it's like, okay, to turn up the O2. But if we're not effectively ventilating, we don't have good air entry, we're not moving air, turning up the oxygen isn't going to do anything, right? So we're not going to be oxygenating anything. So it's better to wait until you have effective ventilation, or as per NRP, if you're starting chest compressions, to turn up your oxygen then. I find this is the hardest part. If a baby is born without a heart rate or a heart rate less than 60, you still have to go through the steps of ventilation. So we don't directly go to CPR, and that's a huge, that's an instinct, right? This heart's not beating, let's provide CPR. Go through your steps. Honestly, going through these steps should take 2 to 3 minutes, okay? So provide the steps to try to establish effective ventilation. A lot of the time, the heart rate will increase, honestly. Like it's weird magic that happens. Like you get this baby and they're like, they don't look good. And then you give them effective ventilation and then they cry like 2 minutes later. So that's why I suggest do NRP and practice that part because it's really hard to do. Okay. So we talked about UVC really quickly and Sarah's right. Like there's a bit of it's procedurally challenging, but again, it's one of those things that I suggest getting a little bit of muscle memory for and just practicing, just going through the steps. If you have any capacity for simulation in any of the sites you work in, there are some sim dolls that have UVCs that you can practice on, umbilical cords you can practice on. But these are the steps and I sometimes just go through them in my head so that I remember them. If you need an emergency UV, or if you have a baby that you're stabilizing and you're waiting for transport, they have a sugar in their boots and you need access, you can put in a low-lying UV in this way. So these are the steps. And when I find sometimes when I put them out like this, it doesn't seem as overwhelming to me at least. But you clean the area, you tie the cord so that there's not a whole lot of blood loss, you cut it, and then you look for the vein. The vein's gonna be the larger floppy one. You identify it, you might need a forceps just to open it a little bit. And then you take the catheter and you thread it in. It doesn't need to be a high UV. You can get to usually 5 or 6 centimeters, pull back, and if you get blood, that's it. You just need to go in until you get blood. And once you get blood, you can, if it's an emergency resuscitation situation, you hold it and someone will push the epi, or if you're using this as a low-lying UV, then you secure it with a stitch. Okay. I recently received a baby from Quesnel that was born preterm there, and was super impressed with the GP there who had put in a UV and taped it in the most elaborate, amazing way I have ever seen. But it was secure. That thing was not going anywhere. And it was great. Yeah. So try to go through them maybe once or twice and it won't be as hard. So post-resuscitation, so you have a baby, they're stabilized, maybe you have them on a bit of CPAP, maybe they're not needing any respiratory support, you're waiting for the team to get there. The things you need to remember to be checking, so thermoregulation, babes get cold, especially during resuscitation, so you probably need lots of warm blankets under a warmer. We need to be checking their glucose in preterm babies. There's a whole algorithm through the Canadian Pediatric Society and ACORN that will help guide you when you need to be worried about glucose and what you should be doing. Decompressing the stomach is really important, especially after CPAP or PPV. Their stomachs get huge. You want to put an OG or an NG and pull off that air. And then, yeah, do you need IV or UV access while you're waiting? So do we need to support the glucose? Do we immediately need to give antibiotics? And in which case, depending on what resources you have at your site, you can try to go for either one of those. And hopefully the team will come and pick up this baby shortly. That was all for me. Does anyone have any questions about that? So yeah, MaBAL and Charlie are like always available to support these cases, you know, particularly with this baby that came to me from Quesnel. You know, they called me to receive the baby in Kelowna, and I said to the physician, well, have you called Charlie? And he said no. And then he ended up calling Charlie, and Charlie supported him while they were waiting for transport. And I think that that was really helpful. And I've done that for other communities as well. So we're always happy. We can see what's going on. We can walk you through steps and walk you through resuscitations and give you advice. So a lot of people, at least from my end, I'll put this piece in, are kind of like, well, PTN, are we calling transport first? Are we calling, like, how do we, and it's an ongoing thing with our TVS. We'd love to be more integrated with PTN. But for now, I would say, like, organize your transport, get your advice, and then if you need ongoing support, call Charlie. And I don't know about you, Sarah, if that's something you would say with MaBAL too. I guess it's a little different if you're in an active delivery.
Well, that example of like the cord prolapse, you know, from Chetwynd, like it was all hands on deck. And so they had one of their docs calling transport and working with them. And then I was sat with them at the bedside. And, you know, it was just a great team effort. We were all talking the same language and reinforcing what each other were doing. So I think it's yes and both and.
Absolutely. Yeah. Yeah. And, you know, I have also in the past called PTN and set up transport, so that allows the physician on the ground to go and do the active management that they need to.
Exactly. Yeah.
Yeah. Thank you guys for attending this. I hope it was useful, and I hope we can share the slides. I'm just going to exit this.
Yeah, I think I have Taylor's email and Adam's as well, but we can definitely send them the slides. And also, if you guys are not familiar with all of the pathways that you can access, because in addition to Rudy, I think Adam, you said you used Rudy before, MaBAL and Charlie, there's also Rosie, which is the critical care line. And there's also some lines that are quick reply. So they're not necessarily available 24/7, but they're dermatology, hematology, that sort of thing. So yeah, it's great to have all these resources, and we're just hoping to spread the word a bit more so more providers can take advantage. Thank you so much, Sarah and Alicia. That was really helpful. This is a recorded session. So although there was quite a low turnout today, I have actually recently discovered that a lot of nursing stations have, I think, it might be a Friday morning or something slot where they do some admin and work. So that actually might be a better time for us to be planning these sessions going forward. So they might be a bit more of an audience. But anyway, this will go up on our channel, and we'll share it out so people can watch it, not live, but still get the same value. So thank you very much.